FlightBridgeED Podcast series.
Hey everybody, Eric with you. Today we're going to jump into a nightmare series case study, and I know that we've done quite a few of those. I think we've done maybe 7 or 8, and they've been very, very successful. And I think from the emails that I've got, we see a lot of teaching aspects, and we can apply those, and we can actually think of those and apply those to real cases that we've actually had as well. So I think it's a great way to teach. It kind of brings the patients to life. The case that we're going to present today is very, very detailed. We'll be able to utilize a lot of the podcasts, a lot of the topics that we've went over so far in the last 2 years on this actual one podcast. Before I get started, I do want to announce we have established a YouTube channel for FlightBridgeED. The YouTube channel is going to be released in the next couple of weeks, and we'll be doing video demonstrations on everything you can imagine, critical care-wise. We'll do a lot of ventilator stuff. I'll actually demonstrate different aspects of the LTV 1200, and so we're pretty excited about that. So be looking for that. If you aren't a subscriber to our newsletter, I encourage you to go on our website and just sign up. It's a free service. You can always opt out. We obviously always release the newsletter along with our podcast. So just be looking for that, and that's how we'll announce the YouTube channel, and tell your friends. Again, we completely realize that we're nothing without you. We're nothing without the listeners. Started experiencing some respiratory fatigue, some COPD exasperation. And during the transfer, as she arrived at this new hospital, she was actually found to be in respiratory arrest. At that point, the ER physician attempted intubation, got intubation, but shortly after intubation, she went into cardiac arrest. So you and your partner arrive at this hospital. So she's already been transferred from a very tiny rural hospital to a larger hospital, but it's still not a definitive facility with a high-level ICU, very small 3-bed ICU. As you walk in, you find the patient lying semi-Fowler. She's currently on the ventilator. She's got a tidal volume of 550. She's got a frequency of 18, and she's overbreathing the ventilator by 14 a minute. Her current PEEP setting is 8, her FiO2 is 40%, and her peak inspiratory pressure is 92. Her plateau pressure is 58. Now we're going to stop there, and I'm going to explain at this point what all that means. So again, remember all of our lung protective strategy. Our tidal volume needs to be based on our ideal body weight, and we always start at 6 mils per kilo. And remember the strategies. We either have an obstructive strategy or an injury approach, an injury strategy. So at this point, we can kind of clue in. This is a patient that has a history of COPD. She's got a history of lung cancer. She's in remission. At this point, it's a little too early to kind of identify, is this a COPD ventilatory failure? Is this an obstructive approach? Or is this an injury approach? Is this an oxygenation failure? Now, this patient, ideal body weight based on her height was very tiny. She was approximately 50 kilos. So right there, based on that, her tidal volume is excessively high. Now, her frequency is set at 18. I don't have any problems with that. And she's overbreathing the ventilator by 14. So there's a few reasons why that may happen. The first thing is identify what mode of ventilation she's in. Remember, the 2 main modes that we're going to see, assist control and SIMV. Assist control is going to be based on the patient triggering a breath, but the ventilator never allows the patient to take control of that ventilator, and it's going to actually deliver a full tidal volume breath for the patient. So if the patient's sedation, if their pain management aspect is very poor, and they're consistently triggering that ventilator, they're getting full tidal volume breaths, and in her case, she's getting 550 mils of tidal volume every time she triggers that breath. And she's only 50 kilos. So her tidal volume should only be 300 mils. So that right there is a big red flag. The other reason why she may be overbreathing the ventilator is she compensating? Is she in a severe metabolic acidosis and she's compensating, trying to protect her pH? And that's something you always want to look at and identify. Her PEEP is 8, and for me, if her PEEP is 8, her FiO2 is 40%, really don't have an issue with that at this point. But then we get to her PIP, her peak inspiratory pressure. And remember, your PIP should never exceed 35. And your PIP is a correlation the ventilator spits out based on an algorithm and it looks at the amount of volume you're putting down those airways. It's looking at complete compliance of that respiratory system. It's looking at how quickly that breath is delivered. And it takes all that stuff into account, and it's going to give you a number. And we know that this is something that we have to watch, and it needs to be lower than 35 centimeters of water. Now, if you're taking the FPC or the CFRN exam, really textbook-wise, they say lower than 40. But a lot of the air medical providers, I know a lot of the top 3 as far as the size, they're a little bit more conservative, and they like to maintain a PIP of 35. So if her PIP is 92, that could be from multiple reasons. Is she overbreathing the ventilator? In assist control, is it triggering? Her sedation status is very poor, and it's causing severe anxiety, and she's having breath stacking. Well, that could definitely cause a high PIP or a high peak pressure. Is she in some type of COPD exasperation? Well, we're going to be able to identify that with our primary assessment, and we'll kind of look at that here in a few seconds. So those are the things we're going to look at with our PIP. Why is it 92? And that's excessively high. Does she need to be suctioned? Is the vent circuit kinked? Is the ET tube kinked? All those things can be looked at. Go through your dope mnemonic, look at your equipment, look at the patient, look at those things. And then we get to the plateau pressure. And the plateau pressure, remember, is the most important pressure that we can ever look at. We need to always be monitoring the plateau pressure and identifying if this is a physiologic norm, which is below 30, or if this is excessively high, and that's a pathologic finding. And that's something that, remember, is correlated to alveolar health. So if we have too much pressure exerted against those alveoli, then those alveoli, the diffusion potential is actually decreased, and we're going to have very, very poor diffusion. So at this point, we've identified these vent settings, we've looked at those things, and now let's look at the blood pressure. Her vital signs are 64/32 for a blood pressure, so obviously very hypotensive. She's got a pulse rate of 155, sinus tach, and she's got an O2 saturation of 88%. At this point, when we look at a blood pressure of 64/32 and her heart rate is 155, we have to ask ourselves a few questions. Is her rate that high because she's compensating? Or is her rate that high because she is on a medication that's causing her rate to be that high? And remember, a lot of times you can have a medication, and dopamine is a perfect medication that causes this phenomenon. And I've talked about this many, many times. And a lot of these smaller facilities, and I don't know if it's because the education or they haven't seen the trials and the research, seen what these level 1 facilities are doing. But dopamine at 20 mics per minute is very counterproductive. Once we reach 10 mics a minute on dopamine, you're going to have lower cardiac output. And so dopamine, again, is best in that situation where you're hypotensive and the patient has an associated bradycardia. So once we identify the blood pressure, the pulse rate, we have to look at the O2 saturation. Her O2 sat is 88%. Now, obviously, most protocols out there, we've learned that we want to keep an O2 sat of 92, 93%. Some may be at 94%. But we also have to think of this from a critical care standpoint. Why is that O2 sat 88%? How do most patients that present like this, what's their underlying metabolic arrangement? And most of the time, it's going to be a metabolic acidosis. And we know in a metabolic acidosis, this causes a shift on the oxyhemoglobin dissociation curve to the right. If you're unfamiliar with the oxyhemoglobin dissociation curve and the physiology behind it, we did do a podcast a few podcasts back. And so I encourage you to go and look at that. And we go through an in-depth look at how that plays into our care. But when you have an acidosis, when you have raised acid, which is the CO2 aspect, when you have raised temperature, right? This patient could be septic. We don't know that yet. Those things drive the oxyhemoglobin dissociation curve from the middle to the right. And we learn that oxygen, its normal binding affinity, is now actually decreased. If you remember, oxygen actually diffuses through that alveolar capillary membrane, diffuses across that membrane, it dissolves into the plasma, 2%, and the rest actually attach to hemoglobin, which accounts for about 90% of our oxygen. And our body actually utilizes the plasma stores first, and the rest is just stored on that hemoglobin. And in a normal homeostasis, we actually deliver about 1,000 mils a minute of oxygen, and we use a small fraction of that. But in cases like this, where you have a very high demand, we need those oxygen stores. But a phenomenon like acidosis actually kind of makes the hemoglobin's affinity for oxygen change. And so we learn that a right shift is right for the patient. And it's right for the patient for one reason, because now the oxygen can't attach to the hemoglobin. The affinity for oxygen, hemoglobin doesn't want it anymore. So it tries to attach to the hemoglobin and it completely dumps it off to the tissues. So in this phenomenon, if your O2 saturation is a reflection of oxygen attached to your hemoglobin, and you have a right shift on the hemoglobin curve, and it's dumping all that oxygen stores off to the tissues, that makes you have good tissue oxygenation. But it's going to show your O2 sat being low. So this is where looking at this from a critical care perspective, kind of globally, should make you look at this and go, all right, an O2 sat of 88%, I'm not really worried about this. They probably have a partial pressure of oxygen, a PaO2 or a PO2, the amount dissolved in that plasma, is probably very, very high. At this point, let's look at the medication she's on. She was on dopamine at 20 mics a minute. And so again, that's to me what's causing this tachycardia. And so why is this a big deal? Well, remember, dopamine, if it increases that rate that high, what's the most important aspect of your cardiac cycle? What's the diastolic side? That diastolic side is essential. If you look at your MAP blood pressure, your MAP blood pressure is 2/3 your diastolic pressure. If you look at your pulmonary artery's sole purpose is not to deliver deoxygenated blood, it's to maintain diastolic pressure. So the whole diastolic phase of our heart, and if your heart rate is so fast that you can't fill that left ventricle and clear that left ventricle appropriately, your blood pressure is going to be inadequate. So this is really essential to fix immediately, because remember, we have to have a MAP blood pressure of 65 to, number one, perfuse our brain and to perfuse our kidneys. For our brain, if our MAP blood pressure drops down into about 50, your brain is actually going to start losing oxygenation, and it's going to be a real bad situation. For your kidneys have to have a MAP blood pressure of 60, 65. 65 is that golden number. If it doesn't have a MAP blood pressure of 65, it recognizes that, and it basically stops perfusion, and it stops producing urine. So we have to understand that we have to fix this blood pressure. We've got to drop that pulse rate. The next medication she's on is Levophed. She's on Levophed at 16 mics a minute. And then the nurse says that they've given her 2 units of packed red blood cells and 1 unit of FFP. Now, you as a flight crew need to do a primary assessment. And on primary assessment, you obviously noted these vent settings, and you listen to lung sounds. Remember, lung sounds are a huge, huge thing in primary assessment. Listen to lung sounds. It tells you a lot of things. And on auscultation of lung sounds, you reveal a completely silent chest. Very, very little air movement. So right there, you should automatically think, all right, this is a ventilation failure. For some reason, this lady has had an exacerbation of her COPD, and that's the main issue here. That matches her PIP of 92 and her plateau pressure of 58 also. But why is she hypotensive? So at this point, you need to be asking a few questions. And this is where labs are a huge thing. And that's why it's so important to understand lab values. And the big one here, because she has had an upper GI bleed, is what's her H&H? Remember here, your hemoglobin concentration is absolutely directly affected to how we store oxygen and how we deliver oxygen. And if we have a depleted hemoglobin concentration, then we're going to have inadequate oxygen delivery. And so her H&H was actually 8 in 22. So it's very low. So they had given the 2 units of packed red blood cells. They had given 1 unit of FFP, which is great. And at this point, we have to look at now, how are we going to approach this patient? What types of things are we going to do to turn this patient around? Because she is extremely unstable. She's already been in cardiac arrest 1 time. She was resuscitated successfully with CPR and 2 amps of epi. But why did she arrest, number one? And what's going on? Why is she so hypotensive? Does she have an associated sepsis? Does she have a pneumonia? Does she have ARDS? What has precipitated this event? The other thing we have to look at is we've got to change these vent settings. We have to look at these vent settings and we have to identify what can we do immediately to correct, number one, this plateau pressure and get this PIP down. And so from there, we have to also look at how are we going to approach this patient? Is this obstructive approach that we've learned? Remember, the obstructive approach is for your COPD and asthma patients. That's a ventilation failure. That means we lower the respiratory rate down to 10 or 12. We give a good physiologic normal tidal volume. And we extend the ID ratio out to 1 to 4, 1 to 5, 1 to 6, and really optimize alveolar emptying. So there's a few things here that we need to know beforehand. And this is where this case gets very, very complex. There's one question you need to ask as a clinician here before you do anything. She's already arrested once. That should be a red flag. Why did she arrest right after intubation? People arrest right after intubation for two reasons. Number one, in sepsis. In metabolic acidosis, they arrest after intubation because their pH was critically low and they didn't have enough minute ventilation during or after the intubation, and it caused that pH to go so low that they went into a brady arrest. The second reason why patients arrest is based on our trauma patients. If we have a trauma patient that is compensating, they're hemorrhaging out, they're hypotensive, and we RSI them. And if you listen to my podcast on neosticks, that's the whole research on giving neosticks prior to RSI. And we give succinylcholine and we basically relax everything. Imagine what happens. The only compensation they have is gone. So for her, this is a medical situation, and you should automatically be thinking, does she have a metabolic acidosis? So here's the question you need to ask, and here's why. In the ventilation failure approach, the obstructive approach, the whole way we protect the patient to optimize that exhalation process is to lower that respiratory rate down. If we lower the respiratory rate down, what does that do to the CO2? Remember, there's a correlation between CO2 and your pH. For every 10 points that CO2 either increases or decreases, it has an opposite effect on your pH by 0.08. So what I mean by that is, just for simple math, if your pH is 7.0 and your CO2 is 50, and we drop that CO2 from 50 down to 40, so we dropped it 10 points, your pH is going to go up by 0.08. So now it's not 7.0, it's 7.08. So you can affect change with that on the positive side, but you can also do that on accident on the negative side. So for her, was her pH critically low? They didn't successfully manage her airway in a way that was optimizing time. She probably was very tachypnic. She probably had a very high rate prior to intubation or prior to that respiratory arrest. And that plummeted her pH. Because remember, if you're hypoventilated, if you stop being ventilated, your CO2 climbs. CO2 has to be constantly metabolized and blown off. So here's the question. Obstructive approach, she's a ventilation failure. You've identified a silent chest. You've identified a PIP of 92. Your whole approach needs to be focused around lowering that rate down and getting that expiratory time lengthened out. But you can't do that if you have a patient that is in severe metabolic acidosis. She's already breathing at 18 plus 14, so about 32 times a minute. So you need to ask what her pH is. And ironically, her pH was extremely low. It was 6.97. So her CO2 was 88, which made sense, right? She's retaining CO2. She's a COPD patient. She has a history of COPD, and so she probably lives at a higher range. Her bicarb is 16, right? So that's going to be a very low amount of base. It means that there's a high amount of acid. That means there's a metabolic derangement. The kidneys are in play. So she's definitely in this is called a mixed disturbance. And her base excess is negative 18. That base excess of negative 18 means that basically she has a severe metabolic acidosis. There's multiple things that are playing into this acidosis. And for this podcast, I'm not going to break down on how to identify your base excess and where those acids are coming from. But this kind of plays into, now what do we do? This is a head scratcher. This is, how are we going to deal with this patient? So your approach basically at this point is going to be changed. This is where you kind of have to wing things a little bit. You have to try things. And so we know that to reduce our plateau pressure, the first thing we always do is look at the pathophysiology. Remember, our plateau pressure is 58 on her. We already identified that volume is high, right? Her tidal volume should be 300 mils based on her weight, on ideal body weight. So her tidal volume is high by 250 mils. So that should be the first thing that we do. We've already identified the pathophysiology. There's nothing we can physically do right now to change that. She doesn't have a tension pneumothorax or something like that. So at this point, we need to lower that volume down. So get it down to 300 mils and recheck the plateau pressure and see if just that fixes that plateau pressure. The other thing that we could do is change the mode of ventilation. And she was on assist control, and she was overbreathing the vent by 14 a minute at a huge tidal volume like that. So is her PIP a result of not only her ventilation failure, but her getting all that volume and that volume building up? She's got a huge rate. She's got a ventilation failure. She can't get all that back out. So she's got really high peak pressures. So what we had decided to do is we actually took this patient and we gave a small dose of fentanyl. We stayed away from a benzodiazepine. We gave 50 mics of fentanyl to try to see if that helped her pain and sedation, and switched her to SIMV. Now, why use SIMV? Well, remember, especially in a patient that's overbreathing the ventilator like this, she's compensating. SIMV is going to allow her to take spontaneous breaths. Now, it's important to keep her sedation, keep her pain management at a very therapeutic level. If you give her a little bit too much, which is all right, just remember to increase that rate, especially with her with a pH of 6.97. She needs to be ventilated at a rate of 34 to 36 a minute, just to make sure that pH doesn't drop any further. Because if you think, if her CO2 goes up another 10 points, her pH is now 6.89. And I'll tell you, that's probably going to be a cardiac arrest situation. So in this situation, and for this podcast, I've changed a lot of the things, but because I think this is a great teaching scenario. But in this situation, if I didn't ask what that pH was, I would have probably killed her. She would have arrested because I would have went the obstructive approach. I would have dropped that rate down, and her pH would have plummeted. So it's very important to try to get all the information. One of the things I've been asked many, many times is, when do you ask for an ABG? We're taught not to sit at the bedside, and I'm not saying you sit at the bedside. If anybody knows me and has flown with me, you'll know that I'm very quick on scene. I want to be in and out. I don't want to sit there forever. But if you're very polite when you come in, you're humble, you ask early, can they get an ABG, or is it possible that they get an ABG? Those things can be done in 5 or 10 minutes. Ask if an RT or if somebody can draw an ABG really. At this point, we need to also deal with the blood pressure. So the first thing you should be thinking is we need to get rid of that dopamine. That dopamine is causing a huge issue. So start titrating that dopamine down, and you need to add some other pressor. So Levofit at 16 mics, that's a pretty good dose. So add something else that's going to have some alpha squeeze. Neosynephrine is a great medication. So, start neosynephrine, very low dose neosynephrine, and see what happens. And that's exactly what we did. We started neosynephrine. We had her on Levofit. We got rid of that dopamine, and we immediately saw a change. Her heart rate went all the way down to about 105, 110 range, and her blood pressure immediately went up into the 80 systolic, and I believe before we even left the hospital, it was around 90 systolic. As far as her O2 sat of 88%, remember, she has a severe metabolic acidosis, and I'm not really concerned about an 88% O2 sat. She's on an FiO2 of 40%. So what can we do to optimize that? Well, we could immediately increase that FiO2 to 100%. Again, that's relative because it's based on how much oxygen is attached to that hemoglobin. And I know based on her acidosis, she's got to be a right shift on the hemoglobin curve. She's going to be offloading all that oxygen to her tissues. And so her oxygenation status is actually adequate. It's just not showing on her O2 sat. The other thing we have to deal with here is she's on a PEEP of 8. Remember, COPD patients, asthma patients, they don't have a true oxygenation failure. If they are hypoxic at all, it's secondary to poor compliance from the air trapping and auto PEEP, and that causes that chest wall to become rigid. They become very fatigued, and they can't take in a good minute ventilation. Obviously, we have to have a good minute ventilation. We have to move air, enough air to cause gas exchange. And so the oxygenation side of things on cases like this will be taken care of if you fix the ventilation failure. So at this point, we have to really look at the ventilator side. We've addressed the blood pressure. We've changed those medications. We've dealt with her sedation. We've given fentanyl. We've looked at the labs. We have identified she's got a low H&H. They've given the packed red blood cells. They've given the FFP. We understand that her ABGs are horrible. We understand she's in a severe metabolic acidosis, and we understand that we can't drop that respiratory rate. We've changed her mode to SIMV. We're allowing her to breathe at the rate she wants to breathe at. We've got it set at 34 a minute. We need to deal with a PEEP. So again, the PEEP is causing more pressure. And so COPD, asthma patients, that obstructive approach, you need to turn the PEEP off, because they have a significant amount of auto PEEP already. Remember, intrinsic auto PEEP is 3 to 5 centimeters of water, and you can have patients like this be in the 15, 18 range. And if you add another 8 of PEEP onto it, think of how much PEEP these patients are actually having. So she needs to have that PEEP taken all the way off. We raised her FiO2 to 100%. We've lowered her tidal volume down to 300. We've got her rate set at a high range, 34 to 36, to try to optimize and protect that pH. And we're going to recheck that plateau pressure. If we still don't have a change in plateau pressure that's lower than 30, then we have to take some more steps. Now, I remember, based on her sedation and making the changes to SIMV, suctioning her, we dropped her PIP down. Her PIP dropped down into the 60s, and her plateau pressure dropped down into the low 40s. So we were seeing a positive change in the right direction. But it's still not in the realm where you want it to be. And for me, the PIP being high like that is secondary to probably at this point her airway narrowing, her bronchial constriction. And we can deal with that by starting an inline neb, maybe giving some Solumedrol, giving an anticholinergic medication like Atrovent to decrease those secretions. So that can be dealt with. The plateau pressure is still something that we have to fix, though. And so we've learned that if we can't fix the pathophysiology, if we can't lower her plateau pressure by lowering her tidal volume down, then we need to change to pressure control ventilation. So at this point, we need to switch to pressure control ventilation. And that's exactly what we did. We went to pressure control. Remember, you identify her PIP, you add the PEEP that she has on, which we dropped to 0. Her current PIP was approximately 60, but remember, we can't utilize that. So our top point for our inspiratory pressure on pressure control is going to be 35. We never want to exceed that. So we set it at 35. We started cycling that through. We identify at a pressure of 35 what we're actually getting based on her chest compliance. And we were getting exhale tidal volumes in the 320 range. And based on that, we actually started seeing the patient do better. By the time we got out to the aircraft, her blood pressure was almost 100 systolic. We maintained her rate that high, because at that point, you have no way to identify if your pH is going either direction. I mean, you're kind of shooting blind. Unless you have an iStat machine and you can continually check that. At that point, I'm going to maintain that rate as high as I need to. I'm going to make sure that pH doesn't drop, and that's exactly what we did. We continued with doses of fentanyl. We were doing 50 to 100 mics once her blood pressure got up. We went with very low dose benzodiazepines, because remember that we, number one, need to deal with the pain more so than the sedation. And fentanyl is an excellent medication that, number one, deals with the pain, very good on blood pressure. You saw that we gave that fentanyl dose with a blood pressure of 64/32, and we didn't see any decrease in blood pressure. So don't be afraid to give fentanyl. You just need to give it in lower doses And in lower doses, you're not going to have that catecholamine release. You're not going to have the effects that you would with morphine, which has histamine release. And we continue to give that because remember, fentanyl is a very fast-acting and it has a very short half-life. So you have to give it very, very often. So give it every 5 minutes. And I kind of do that. I'll give it 2 doses for every 1 dose, maybe 2 milligrams of Versed. And that's exactly what we did. We kept monitoring her sedation status. We basically set a rate on the ventilator of 36. We weren't really worried about her overbreathing the ventilator at that point. We were more worried about making sure she was comfortable. Because another aspect of the ventilation side is COPD patients, their respiratory lung muscles, their intercostal muscles and things like that, they're very fatigued and they actually need to rest. It's good to allow them to fire those muscles a little bit, but you don't want them to overexert. And she obviously was really overexerting herself. Her sedation status was really horrible. She was overbreathing the vent by 14 a minute prior to us getting in there, or attempting to, I should say, and assist control was actually giving her those full tidal volume breaths. So that's all I have for this case study. As you can see, this is a very complex case. You need to ask the right questions. There's a lot of things going on here. If you have any questions regarding this case study, please email me at eric.bauer@flightbridgeed.com, and I'd love to talk about it or show you different aspects of how we can break this down. Again, I want to thank everybody. I want to thank everybody for following us and being patient this last year, and we're really excited about this new year and all the things to come. And we'll talk to you soon.
We want to thank you for following FlightBridgeED.